Okay, so we are going to continue on with conditions of the newborn and starting off with retinopathy of prematurity. This is a condition that happens um, basically because of the vasculature that is in the back of the eye is so susceptible to damage and to bleeding that anytime that there's a large amount of hypoxia or even a large amount of hyperoxygenation, you can have lots of vasoproliferation with the bleeding scar tissue, and these can detach the retina or distort it. And so we have newborns, especially premature ones, evaluated for retinal damage. We kind of look at three criteria. We look at the gestational age and how old they are. Are they premature, like in that 32-week range, 33-week range, or lower? And did they have a lot of exposure to oxygen? Were they intubated? Uh, any sort of arterial pressure issues, and then as well as if they have any known damage or known bleeding in the retinopathy or retina. And if that occurs, then we rate it and we kind of define those stages as 1 through 5, 5 being the worst. And so infants are typically seen somewhere around 4 to 6 weeks of age by an ophthalmologist who typically will come to the NICUs to perform those. And they has to be done on all infants that are less than 30 weeks of gestation at birth or less than 1,500 grams at birth. But oftentimes we'll do it even at 32 or 33 weeks if there were a lot of complications or a lot of oxygenation, that sort of thing. Some of the things that we can do as nurses to help prevent retinopathy of prematurity is that during oxygen administration, we can watch for fluctuations in oxygenation and try not to hypoventilate or hyperventilate a child. And we want to wean them off of oxygen as quickly as possible. Other things we try to do is we try to decrease those constant bright lights. We use the blankets over the bed to provide shading. And then we're, of course, doing the referrals to ophthalmology. Another common disorder for infants that are born prematurely is GERD or gastroesophageal reflux disease. We oftentimes will see frequent spitting up, irritability, maybe only tolerating small amounts of food or refusing to eat. Some infants will arch their backs when they're feeding, and they may have frequent regurgitation, hiccups, coughing. But oftentimes we'll also see them having difficulty maintaining oxygenation while feeding, and sometimes having some apnea spells, and that can tell us that something else is going on. And we do want to make sure that we're doing our nursing care in a way that we're assessing whether or not they have any residual from their feedings, determining if they need thickened formula or if they need their head of the bed raised, and of course making sure we're not propping bottles, that we're feeding infants slowly in the upright position and watching for any sort of apnea or color changes during feedings. So conditions affecting the late preterm neonate can include things like hypothermia, hypoglycemia, feeding issues, and jaundice. Again, late preterm infants are going to be those 35 to 39-week infants, and so they should be fairly stable, but they'll also have some other issues that are going on. We've talked a lot about hypothermia and cold stress in clinical and in labs and in other lectures as well, but preterm infants are at higher risk for hypothermia because they have increased skin surface area and they don't have the accumulation of body fat, and they definitely don't have the neuro maturity to keep their posture flexed, which helps retain heat. And so we oftentimes are focusing in on prolonged cold stress and making sure that we are rewarming babies. And then, of course, hypoglycemia usually follows any sort of cold stress. So preterm infants, even late preterm infants, need higher energy needs as far as formula or breast milk counts. They also oftentimes are very immature in their ability to coordinate breathing and eating. So sometimes we end up putting in OG or NG tubes to give tube feedings, and sometimes we can help parents with breastfeeding along. For postterm infants, we really do see a few other serious things that can happen, which are meconium aspiration syndrome, which typically leads to persistent pulmonary hypertension of the newborn. And these are usually larger babies, and they're very, very sick. So meconium aspiration syndrome happens when the newborn's delivered through meconium-stained amniotic fluid, and it aspirates that fluid into its lungs, and those obstruct the alveoli or the lower airway. So oftentimes we'll see a meconium delivery, and then oftentimes they will have really loud rales and rhonchi on auscultation. And typically we'll have to do an x-ray that'll show some opacities through it and some atelectasis like pneumonia. So our nursing care really centers around, assessment, respiration assessment, and then sort of things like, providing oxygenation is needed, oftentimes with a CPAP, suctioning or resuscitating if that kiddo is really, really ill. And then sometimes chest physiotherapy or PT can come in and help things, and then lots of medications to help. We want to keep these babies sedated, and they don't tend to respond to touch very well, partly because they develop this persistent pulmonary hypertension of the newborn. And in this case, it's oftentimes caused by meconium aspiration, although they can get it from sepsis or pneumonia. And these babies typically have low APGARs. They typically have central cyanosis and tachypnea with really severe grunting and retractions. And their blood pressure is normal, but their pressure inside their lungs is not. And so for persistent pulmonary hypertension of the newborn, which we also call PPHN, we really focus on hyperoxygenating these kiddos. Again, they're post-term, so we aren't going to cause the retinopathy. And sometimes we have to turf them to a higher care unit, and they need nitric oxide, which helps decrease that pulmonary resistance, or they need ECMO, which is where we take the blood out and reoxygenate it via machine, and they typically are very, very ill infants. When people touch them or change their diapers, oftentimes they will desaturate down into very low numbers, and so parents generally cannot touch their infants, and we want to try to group all of their care together and do as little touching of that infant as we can. So classifications of high-risk newborns are also done by weight, so not just by gestational age. So low birth weight infant is anybody under 2,500 grams, very low birth weight, less than 1,500 grams, and extremely low birth weights are under 1,000 grams and don't correlate well with survival. So we're going to talk about some other conditions affecting the newborn that typically happen during high-risk situations or high-risk deliveries. So it's very normal for us to be assessing all infants for injury and assessing for things like bruising, which can contribute to jaundice and lacerations, but also we should be checking for fractures. And oftentimes after a vigorous delivery with shoulders or anything else, the most common thing we'll see is a clavicle fracture or a broken humerus. Sometimes we'll see subjunctival hemorrhages, which look really alarming because they're ocular bleeds, but they're fairly common in neonates, and they usually go away within a couple of weeks, but also should be investigated for any other correlating neurosymptoms. So injuries to newborns can also happen that are nerve trauma or spinal cord injury. So we might look for a brachial plexus, which is usually one-sided nerve damage. Generally happens from pulling and stretching on the head and the neck during a delivery, and can require some treatment and may not always get back all of their motion or sensitivity. And then facial nerve trauma, occasionally due to the pelvis or to instrumentation used for the delivery. And then spinal cord injuries are fairly rare, but on occasion we'll have a delivery that's extremely difficult, and a baby can have damage to the spinal cord. So hypobilirubinemia in newborns, post-term babies, that sort of thing, just happens when there's greater than normal bilirubin. And we oftentimes will see this because the newborn intestinal system is sterile. They really have a difficult time breaking it all down, and they keep reabsorbing it, and then that deposits back into the circulatory system and deposits back into the skin. So we call this jaundice, and oftentimes there's a physiological jaundice, which means it's just a normal process. So this could happen because of breast milk not coming in very quickly, small volume feedings, maybe some, kind of things that we expect to happen. And we just want to make sure that babies are fed more frequently and that moms are drinking enough fluids. So we look at all babies and do assessments for jaundice at every shift assessment, of course, and they should be visually inspected by at least 8 to 12 hours of age. Because sometimes jaundice can be early onset, and if it shows up in the first 24 hours, then we know that those babies are at particular risk of really severe jaundice, and it's oftentimes due to a blood incompatibility. So we oftentimes now will use the TCB or the transcutaneous bilirubin monitor to check bilirubin levels in the skin. And if that is elevated as far as a reading goes, then oftentimes we'll be doing a blood draw for total bilirubin. And then preterm infants are at higher risk for pathologic jaundice. So infants that are born before 35 weeks are screened and treated. And keep in mind that the bilirubin levels, once they exceed 15, we don't know where the really bad spot is for that infant as an individual. So we always want to be fairly aggressive in treating jaundice, especially the pathologic jaundice. So we'll use phototherapy, which converts that bilirubin into something that's a little bit more soluble, doesn't have to go through the liver, can be directly go right back through to the stool and be excreted from the body. And it's just important that we keep in mind sometimes babies need an exchange transfusion where we will basically take out their blood and give them new blood and replace it all that's bilirubin free. So transient tachypnea of the newborn is a little bit different from RDS. Remember, RDS or respiratory distress syndrome is something that occurs in premature babies. Transient tachypnea of the newborn can happen usually in late preterm or term babies. And so typically it's very labored, fast breathing the first few hours of life. It usually goes away within about 24 hours. These babies may have grunting, flaring, retracting, circumoral cyanosis, and typically we're offering some oxygen by CPAP or by high flow oxygen, and then sometimes we need to start IVs, but most of the time we'll know that this kiddo's got transient tachypnea of the newborn because it might have been a cesarean delivery or mom's diabetic and that baby just has a lot of fluid that it needs to get rid of. So infections in the newborn usually come from a couple of different sources. So it could be transferred from the placenta in the case of like syphilis, rubella, cytomegalovirus, Zika. And it could be an ascending infection from the urinary tract or the vaginal tract into the uterus from prolonged rupture of membranes or a lack of mucus. And then sometimes babies can have like a birth exposure to something like herpes or bodily fluids, and sometimes they've got exposure to groupie strep. And then sometimes we also have some post-birth exposures to some things like RSV, CMV, yeast, chickenpox, hospital-acquired infections, that sort of thing. And so newborn sepsis, there's some signs and symptoms that we may see. Usually they can be behavioral in that they're not responding as well. They may be in respiratory distress. Oftentimes we'll see hypothermia as opposed to a fever, hypoglycemia, poor tone, that sort of thing, drop in blood pressure. Or we may have a fever and we may have increased bands or immature white blood cell count and inflammation indicators. So infants can also have neonatal exposure to toxins, to things like cigarettes, and they do respond to the nicotine addiction, cannabis, alcohol, also street drugs like heroin, cocaine, methamphetamines, and opioids. They can have exposure to toxins through acceptable opioid substitutes such as Suboxone or methadone treatments, or even to something like mom's seizure medications, antidepressants, antipsychotics, that sort of thing. And so sometimes these babies, in result of that, have some withdrawal signs, and that will typically include tremors or trembling, irritability, sleep problems, really high-pitched crying, tight muscle tone, hyperactive reflexes and seizures. And then some other signs that we see as babies start to withdraw are going to be, yawning, stuffy nosing, sneezing, uh, poor feeding, poor vomiting, diarrhea, poor ability to coordinate their suck. And as it progresses and they're getting deeper into withdrawal, we will see them with active sweating, which is really atypical for a newborn, with a fever or unstable temperatures. So we typically want to assess our infants twice a shift at least, or 3 times a shift if it's a 12-hour shift. Every few hours, we'll typically do it right after a feeding when the baby should be most relaxed. And then we'll use a scoring system very similar to this. It may be done in the computer, or it may be a paper tracking form, depending on where you're at. And you can see here, it shows you all sorts of things. We would give it points or score it for each category and anything that you're noting on assessment. And then based on that, the doctors decide when that infant needs help withdrawing from those medications. Do we need to replace it with something? And then, pain assessments. Infants can feel pain, and oftentimes if they're withdrawing, they do feel some pain. So we will be checking for that. But also due to birth injuries and other things, we're always assessing for fetal pain and discomfort. For infants in the special care nursery, they may have a specific pain profile, a premature PIP profile that we'll use sometimes to judge whether or not that infant may be in pain, and we'll use those scores to help us guide care for that infant. So oftentimes people tend to ignore infants' pain, but it is very important, especially in the neonatal infant, to treat pain for that development of trust versus mistrust. And so, it's always important to keep in mind that babies have lots of different pokes and things like that that are going to cause pain. And so we may offer lots of non-pharmacological benefits as far as skin to skin, sugar water type thing, that sort of thing, sucking on a pacifier, breastfeeding, those sort of things to help infants cope with their pain. Newborn screening, we've talked about the PKU a little bit, and we talked about kind of this 3 disorders, or the 3 areas that we watch for. That PKU tests for metabolic disorders, hematological disorders, and endocrinopathies. And so that's kind of like what we went over in lab class, talking about all the different tests. And there are lots of resources to be able to go look for and to determine if a child needs genetic testing or they need nutritional counseling, that sort of thing. So some of those metabolic conditions that it tests for are phenylketonuria or phenylalanine allergy, and it's their inability to break it down with an enzyme and eliminate that protein. It can build up in the brain and cause brain damage. Galactosemia, they might need a lactose-free diet, maple syrup issues, homocystinuria, and then biotinidase deficiency. So there's lots of metabolic conditions that we don't see very often, and that testing helps us to catch it. Some of the endocrine conditions it tests for is the congenital hypothyroidism, which we've talked about that and how that can cause issues with jaundice for infants, and it can cause delayed cognition and development issues there as well. And the other component that the PKU tests for might be some hemoglobin conditions like sickle cell disease or beta thalassemia. Again, a lot of this is review from our lab classes and from your experiences on the floor, but congenital anomalies, we always want to do our heart screening for infants after 24 hours of age by doing a pulse ox on a preductal and a postductal area, so typically their right wrist and then a foot. And we want to look for whether or not that's a positive screening. Could there possibly be an issue with the heart? And that helps us to flag those down sooner. And congenital anomalies that we might be checking for might be neurologic issues. So spina bifida, that's the one where we roll them over. We're looking at their back to make sure that that spine closed and that there's no meningocele or anything like that. And so we've talked about these a bit. Encephaly is something that we've seen a little bit with the Zika, but most of the time we know way ahead of time that you've got a baby encephaly with no ability to survive. So, and then there's just a side photo of the congenital anomalies that we might see with like spina bifida. everything from a closed area to a tuft of hair to an actual meningocele. Sometimes we'll see kiddos with some congenital anomalies of the orofacial cleft, like a cleft lip or a cleft palate, which again we've talked about in our lab classes, and it can be a genetic syndrome. It can also be exposure to things in utero, and typically we'll do cleft lips are repaired at 3 months and cleft palates at about 6 months of age. A lot of them may need a special feeder called a Haberman to help them grasp onto a nipple. And that really wraps up chapters 24 and 25. Again, a lot of it's things that we've gone over in labs because we've had to look for what's normal and what's abnormal. This just gives you a little bit more information about abnormals and just gives you kind of some reminder moments. Have a great day.